My name is Jackie Sable. I'm a member of the ECHO team, and I'll be facilitating our session. A few quick announcements before we begin. If you've not already done so, please put your name, your email address, and affiliation in the chat box. We ask that you stay muted unless you're speaking. You can use *6 or the microphone icon on the bottom left-hand corner of your screen to mute and unmute. You can also use the chat for communicating during the session. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible. But if there are questions that remain unanswered at the end, we'll always follow up with an email. If you have suggestions for future topics, please share via the chat tool, or you can email us at echo@psu.edu. Please remember that when discussing cases, no personally identifiable information is allowed. We are recording these sessions, and we share all materials and recordings after each session. In the spirit of ECHO's all teach, all learn model, we will be on a first name basis during the session. ECHO sessions always begin with a brief lecture and are followed either by a case discussion or a question and answer time. Today's session will include a brief lecture and case discussion on what comes next after your first COVID case by Dr. Joshua Wee, and this will be followed by a question and answer period. During the lecture, please feel free to put your questions and comments into the chat. We do have a team of specialists from Penn State Health Online, and they'll help to field questions. But remember, this is all teach, all learn, so anyone can share both questions and answers. And we will take additional questions after Josh is finished with his lecture and case. And with that, I'm going to turn things over to Josh for today's lecture.
All right, well, thank you guys for having me. And certainly I've been doing a lot of webinars and conference calls, more than I have in a long time. Just so you know, I have no disclosures. Let me just get towards my first page. So my nursing home is called Renaissance Healthcare and Rehabilitation. It's a 120-bed facility in Southwest Philly. And I had the first COVID patients in the nursing home in the city. The sum total of it is by the end of about 2 weeks, we had 22 cases. We had 6 deaths. Actually, we have 23 cases. We had a patient who swabbed negative twice and was antibody positive. But it was a rough couple weeks. And I've been mainly spending my time since then really helping out other nursing homes sort of wrap their heads around what to do. By no means, I shouldn't say this at the beginning, but at no means am I an expert on this. It's just that I've been through it and have spent a lot of time talking with Swati, Sabine, and Mike Wasserman from AMDA, and just connecting with a lot of folks nationally, Dave Nace at Pittsburgh, Tom Lawrence in the western suburbs of Philadelphia. And this has really become my world for the last 5-6 weeks now. So the learning objectives are helping you switch your facility into disaster mode now, getting your logistics geared up, understanding the key steps of infection control, helping your facility operate at the maximum of its capability, and coordinating support with others. So let's see. Nope. There you go. So this is why we all worry. None of us want to be like Kirkland, where we have out of 130 patients, 80 infected patients by the end of 2 weeks, with 30 some dead, a fourth of the staff infected, and spread all over the national news, and a $600,000 fine. Sorry, I'm having trouble with the slide moving backwards and forwards. I probably should stop clicking the arrow keys. And that is what's going to galvanize us. And I would say, in retrospect, I've learned a lot of things in retrospect. In retrospect, the key step is to switch into disaster mode as fast as possible, which means daily meetings between the administrator, the director of nursing, the medical director, and your infection preventionist. you cannot start talking about this too early if you're a COVID naive building. You cannot meet enough about this ahead of time. There's a building that I just came from, which is why I'm a little bit late, where the medical director's in the building 1/2 day a week, and that is certainly not sufficient. But you have to coalesce, and if you guys maybe haven't had the best communication, well, now is the perfect time to get it together, but you have to be on the same page very quickly, very early in this process. It's just a great time to put ego aside and just get to work at getting your building in shape and changing gears. I think the other thing that I didn't appreciate is how challenging it is to handle staff morale. And I would consider having town hall meetings with your staff before you are COVID positive, but certainly once you are COVID positive, you want to have very regular communication with your staff and having just either town hall meetings virtually, sending out emails, but making yourselves as leaders accessible to your staff. And I mean every single staff in the building, whether it is dietary, administrative staff, nurses, CNAs, just making yourself ready for them. And the question that I have found overwhelming is how do you manage the flow of information? There are certainly websites like CDC, CMS, and Department of Health. There's webinars like this. There's conference calls. But one thing I found is I've had a couple key people that I call when I have a dilemma or have email when I have a dilemma. And these are people that are just a couple weeks ahead of me and have processed the information for me, and that's been a lifesaver. A couple things to sort of get your facility ready for this pandemic is to start simplifying your care. I've heard people say that this pandemic is going to force us to operate the way we always should have, and I would agree with that. So one thing I would do is get rid of all nebulizers in your building. Any PRN nebulizer, switch it to an MDI with a spacer. I would simplify medication administration now, so get rid of all TID, QID med administrations, excessive multivitamins, everything that we should have been doing to simplify care, do it now because you're going to need the extra staff capacity to manage what we're going to talk about next. I've put all routine labs on suspension for the next 3 months. If somebody's A1C was 8.5 3 months ago, I'm going to wait another 3 months before checking it. If their TSH was 5, I'm going to wait 3 months before checking it. I'm not checking it during this pandemic. And then start having a plan to communicate with families. Exactly what do you want to communicate? You're going to have to know your families really well. My uncle is at a memory care unit where they created a pandemic website where once a week they update case counts on there. Needless to say, my nursing home doesn't quite have that type of resource, and my families of my patients don't necessarily like to surf the web. So you have to figure out what works for you. I would be very careful about talking with the press. I would use a professional press relations officer if you have one. And just be careful with people misrepresenting themselves who are trying to get numbers out of your building. So the logistics is once you have a positive in your building, if your goal is to test symptomatic patients, you're playing the wrong game. That would work for influenza. That does not work for coronavirus. So the question is, are you ready to test your whole building, all the patients and all your staff? Where are you going to get those tests? Are you going to get it from your local health system or the Department of Health? If it's the Department of Health, do you have their phone number already? And have you talked to them about this ahead of time? In terms of PPE, let's be real, nobody has enough PPE. The Department of Health, the Pennsylvania Emergency Medical Group, the local health system and the Healthcare Association of Pennsylvania are ways that we have gotten PPE in our building. Masks, you want to have plenty of surgical masks and N95s and a couple of PAPRs if you need it. Gowns, I'll tell you, nobody has ever had enough gowns. People are resorting to ponchos and hand-sewn gowns. Eye protection, ideally face shields, goggles, safety glasses, and a pinch, and gloves. What hospitals don't understand about nursing homes is we do not have surge capacity. So I work at Penn, and they have surged outpatient doctors to the inpatient ward. We always operate at our needed capacity or a little bit less with agency help. And the problem is once you start with coronavirus in your building, if 25% of your staff get infected and another 10% are worried and they just don't want to come to work, and some get quarantined for exposure, you can lose a significant number of your staff really fast. And so the question is, where are they going to come from? Agencies or local hospitals or health systems? The National Guard went into one nursing home this last Monday in Delaware County. The staff also don't understand that they are more likely to infect each other than they are to get infected from patients. So I get very defensive about nursing homes. And the reason that this is not a pandemic that nursing homes are going to be able to succeed in on their own is that this is an issue of asymptomatic spread. It's probably in your building already if you don't know it. It's going to spread in your building. It's not going to be your fault. Even if you passed your surveys and did everything right, that might work for the flu. It's not going to work for coronavirus. And invariably, whenever a person has their first case, they probably have 10. When we had our first case and we ended up swabbing just 1 out of the 4 wings in our building, we ended up having 20 in less than 7 days. And given the incubation period, those other 19 patients were already positive when our first case popped up. There's a good chance your staff is infected as well. I don't have a slide on this, but about 1/3 of my patients have been asymptomatic the entire time. We had one patient that tested negative twice who became antibody positive. And so asymptomatic occurrence or asymptomatic infections is really, really common. So because older adults present atypically, our typical is atypical. AMDA has a screening guide for us. So it's a temperature of 99.5 or higher with cough or shortness of breath would be our typical symptoms. Our atypical symptoms would include GI symptoms, cognitive symptoms, exacerbation of chronic disease, myalgia, sore throat, runny nose, and chest pain. So my index patient was a patient that presented with diarrhea for 4 days and no other symptoms, who then spiked a fever, went to the hospital, and swabbed positive. As you guys know, Swati Gaur is the chair of the Infection Prevention Committee at AMDA. Her first case was a patient with suprapubic tenderness in the presence of an indwelling Foley who developed a fever that got better with antibiotics and still swabbed positive. And so you have to have a very low suspicion for testing for COVID. Now, infection control, hopefully everybody has already closed their nursing homes to all visitors, no group activities, no group dining, everybody in their room with their doors closed, including people who like to fall. Universal staff screening is probably helpful. I think it's another way to detect some people, so that's temperature and screening questions. But the reality is staff will be coming in asymptomatically infected. You just have to live with that. There's a lot of case reports and chatter about hemodialysis patients bringing it into the nursing home, you could consider putting all of them in single rooms or isolating them to a cohort of your nursing home if it hasn't happened yet. PPE is really key. And I think this is probably one of the best things we've done is go to a universal mask with eye protection policy. So everybody from the moment they step into the nursing home has at least a surgical mask on with face shield the entire time, and they don't take it off. They keep it on the entire day. We have one room which we've cleaned for dining. I personally don't eat or drink when I'm in the nursing home. Everybody from administrative to dining services, whether they are seeing patients or not, everybody wears a mask the entire time with eye shield. There's definitely a lot of controversy whether or not N95s are necessary, helpful, or harmful. It's a decision that you're going to have to make. I actually think N95s are better if you can not touch it and if you don't take breaks by taking it off. But if a person can't stand having an N95 mask on for 8 hours, then certainly a surgical mask is adequate. And then you really need to clean and clean and clean again. So for all patient and staff interactions, everybody should keep at least a surgical mask on the entire day with eye protection, ideally face shields or goggles, even if they're just in a conference room talking to each other, safety glasses if you've run out of face shields or goggles. When you're dealing with COVID positive patients or suspected patients, an N95 respirator, I think would be ideal. Eye protection, gowns. Now, if you're short on gowns, keep them for the CNAs who are providing close care or nurses who are providing wound care, or keep them for symptomatic patients over asymptomatic patients. And then if you're really short, just keep them for CNAs for symptomatic patients. And then for COVID positive patients or suspected patients, you need gloves for all those interactions in addition to your normal hand hygiene. So, like I said, no nursing home has a pool of staff that they can pull from. The best way to preserve staff is to make sure that they are wearing the proper PPE all day. And again, I'm convinced that they are just as likely to infect each other as they are to get infected from patients. The CDC actually has an article on mitigating staff shortages. And here's the issue, is when we had one case, they quarantined almost 20 of our staff. Once they found out we had 10, meaning the Department of Health, they told everybody to come back to work with masks. Because even if they are asymptomatically infected, the whole point of a universal mask policy is that they won't pass on the infection to others. And you can't run a nursing home without staff. This is not a made-up guideline. This is on the CDC website, and I gave you that reference because staff may be nervous to believe you on this one. One of the big controversies is what is a COVID unit? Every nursing home that I've talked to, I've connected with probably about 20 nursing homes in Philadelphia. Every nursing home with their first case, the first temptation is to start shuffling patients around. It happens every single time. And there was an hour-long webinar by the Washington AMDA chapter on this topic, and let's just say we don't have an hour right now. But a true COVID unit will have a separate physical location that is separated from the rest of the building by doors. You'll have completely separate staff down to janitors and housekeeping. You'll even have a separate HVAC unit. You may even want to staff it with a respiratory therapist, infectious disease consultant, or a pulmonologist. The question is, who would you move there? Now, most of us don't have this. There are nursing homes that have made these. I don't have this in my building. But we had one wing that we designated as our COVID unit. And the question is, who do you move there? And the answer is you only move your known positives. You do not move the known negatives out of the COVID unit because they actually could be positive because the test is not perfectly sensitive. You don't move patients under investigation into the COVID unit because the question is, how are you going to get them back out? You don't put new admissions or readmissions in the COVID unit either. One question is, what do you do with dementia patients that like to wander? That's a tough one. Ideally, they would be in an area that limits how much they are being moved around or how much they're wandering around. The question is, when do you let somebody out? And I think the most conservative policy would be a testing-based strategy of 2 swabs 24 hours apart. That's pretty challenging because depending on your Department of Health, you might not have enough swabs. I would not follow the CDC guideline of 7 + 3 days, but we'll talk about that as well. All right. So the challenge for COVID is our nursing home has to operate at the maximum of its capability. And it starts with monitoring patients. All patients in the building should be getting screened with a temperature and pulse ox Q shift with a symptom screen. That should be occurring in your facility already. For your COVID positive patients, initially we were doing a temperature and pulse ox every 2 hours. The current AMDA recommendation is every 4, and these are for symptomatic COVID patients, patients with a cough and or fever. If they are asymptomatically positive, I might not do this. I might just leave them at Q shift. And I have had a slew of patients that we did Q 2-hour temperature and pulse ox that ended up being overkill. The temperature you're using, again, is 99.5. The pulse ox is a pulse ox of less than 91 or a drop of 3%. Should trigger a call to the physician. Labs, you might want them every other day if the patient's not eating or if they're lethargic. Blood pressure doesn't seem to be that useful, and it just is another way to transfer infection. And the key for monitoring is that you send the patients to the hospital for hypoxia, which can be fulminant and rapid, or lethargy that's profound where they're not eating or drinking. And ideally, if you do things right, you won't have to send them for testing, simply for being COVID positive, for fevers, for IV fluids, for goals of care discussions, or end-of-life care. I would say that if you feel like you can't handle the patient in the building, send them and just deal with it later. There are people that you are going to send for end-of-life care because you don't have the pieces in place ahead of time. So in terms of therapy, we have partnered with an infusion company to make sure that we can have IV fluids for any patient in the building that we need to. They've been fantastic. We get blood work. We use Tylenol for myalgias. We use meter dose inhalers for respiratory symptoms. Again, operating at the maximum of our capabilities, we do advanced care planning that's incredibly focused. The question is, would you want to be intubated for 2 weeks if a person is full code? And we are making people do not intubate for the duration of the pandemic if they answer that with a no. If the person is already DNR DNI, we ask if they would be okay just staying in the nursing home with IV fluids and labs and a supportive care pathway. And if that's the case, we are making them DNH for the duration of this pandemic. And of course, there's patients that go from being DNR to full code when they hear the words COVID. There are patients who want to stay full code, and you just let that be and you move on. And you could consider developing a separate pulse just for the duration of this pandemic for your patients. The palliative care supportive pathway, the hospice director at Penn, Nina O'Connor, she was my first panic phone call. Actually, she wasn't my first. She was one of my first panic phone calls when one of my patients with hypoxia went to the ER, and the the brother asked if she could come back to the nursing home on hospice. And the hospice was not interested in coming into a COVID positive building due to staffing and quarantine issues. But they developed this pathway for telemedicine support. And because there's no face-to-face visit, it can't be formally signed on to hospice. The patient can't be formally signed on. But it allowed us to get medications in place, monitoring protocols in place, a daily huddle with the nursing staff and bereavement support. And of course, the question is, when do you want to get this in place? And the answer is early. Yep, there you go. Some of the obstacles, our transportation company was super helpful and willing to transport COVID positive patients, but they had no PPE, so they would ask us for PPE. The dialysis centers have been a mess in Philadelphia. They were all under the impression that they were the COVID negative centers, and so multiple nursing homes have had issues with dialysis centers that refuse to do dialysis center. I had a patient that went to the emergency room 3 or 4 times to get dialysis. Got a lot of angry phone calls from that emergency room. So the question is, will they take patients if our patients are positive? Will they take them if they're negative, but from our nursing home that is positive? And will the health systems and the Department of Health help coordinate care? This is one of those situations where either we cooperate or everybody loses. And unfortunately, in Philadelphia, we have not had a lot of cooperation between the health systems, the dialysis center, and the nursing homes. Our first week, our lab company quit on us. They said they didn't want to come into our building. Our radiology company, Mobilex, quit on us. They didn't want to come into our building. And they maintained those positions until all the nursing homes became COVID positive and everybody was looking for other services. Our infusion company was fantastic. So you want to make sure that your ancillary services are ready. Our ER and hospital systems have been useful. We actually have not worked out a system-wide transition of care protocols yet. You'll want to see if your hospice companies are ready to come to your building. Again, the staff are going to have to operate beyond maximum capability. I'm asking my staff to do more than they have ever done before. I mean, who does Q2 hour temperature and pulse oxes in a nursing home setting? You're also going to lose staff because they're symptomatic or COVID positive, they've been exposed and they want to be quarantined, and because they're afraid. And so just as you're trying to surge your staff, you're going to lose your staff. And I would say probably the most important thing I did was not take care of my patients, but take care of my staff. And so it's about being gracious and kind. It's about being encouraging. It's about showing appreciation. It's about answering every single question that they have to the best of your ability. It's helping them protect their families. It's about being visible. It's about giving them breaks and a place to eat. You know, this is where you are asking them to take risks. And you have to show appreciation for them. For families, you're going to have to figure out what you want to share and how often you want to share. Do you want to share your testing strategy? Do you want to share the number of positives, your PPE status, your infection control policies, how you're monitoring patients? Do you want to set up a hotline? Do you want to call your families proactively who are of COVID positive patients to give them updates? And do you want to ask them to assist with advocacy for nursing homes? But you know, if you think about this question from the perspective of a family member who can't visit their loved one, what would you want to know from the nursing home? I mean, this is sort of the list that I came up with. Now for admissions and readmissions, as soon as we became a COVID positive nursing home, the hospital started asking us if we would take COVID positive patients. And I will tell you, we were in no position to take COVID positive patients. We were already pushed to our max, and the idea of taking a COVID positive patient was and we couldn't even consider that. Having said that, we haven't had a new case in almost 3 weeks. And we actually could take a COVID positive patient. We've shored up our PPE supplies. COVID positive patients on the discharge side of things are actually not that hard to take care of. They're fairly stable. They're quite deconditioned. And so they need a lot of therapy. But it is doable now. The question is, do you actually have a COVID-based unit? And do you have the PP and the staffing to man it? For the COVID positive patient, the question is, do they still need transmission-based precautions, and can you quarantine them? This is an unanswered question. Nobody knows if we can trust the testing-based strategy, the non-testing-based strategy, a time-based strategy. This is a real dilemma. So the testing-based strategy is 2 tests 24 hours apart. The other one is 7 days from onset of symptoms or testing, plus 3 days since last temperature. There isn't a single medical director I've talked to that thinks that this is reasonable in the least. And that protocol is made up by the CDC. There is nothing about that that's evidence-based. For COVID negative patients and COVID unknown patients coming out of the hospital, this is where you are going to get caught. One is you cannot believe negative tests. Every patient, all admissions and all readmissions should be quarantined for 14 days. Assume that everybody is pre-symptomatic. Gowns, gloves, face masks, eye shields, solo rooms if possible. So here are my favorite sources of information. AMDA, of course. The Washington AMDA chapter has amazing webinars, including a fantastic one last night that is already posted about how to set up a COVID unit. I have communicated with my fellow medical directors in the area every single day. Last night I was on the phone with Dave Nace at Pittsburgh. The morning after I found out my first patient, I talked to Sabine from Washington. A week ago, I talked to Swati from AMDA. Mike Wasserman and I email probably every day, and Tom Lawrence, who's a medical director in the western suburbs, is somebody that I talk to on a fair basis. But the whole point is not that you borrow the same list, but the whole point is that you have people that you talk to, because there's too much information to process on your own. The conclusion for me is that this pandemic is going to hurt, and it's not going to be easy. The thing you have to convince your staff is that we will make a difference if we do things right. Since we've gone to our universal mask protocol, we have only had 1 staff member get infected at work. Every other staff person was taking care of non-COVID patients and probably got community spread. And it's been wonderful for our staff to know that our meticulous PPE and infection control has prevented the spread of coronavirus to the other wings of our nursing home and has prevented staff from getting infected. I can't tell you how much education I'm doing to the non-geriatricians in my health system. It's stuff we always wanted to say, and it's just that now we get to say it a little bit louder. And don't try to do this by yourself. So we're at the half-hour mark, so I'm going to stop there, and we can go over questions.
There are 2 questions in the chat from Nikki.
Yep.
So Nikki, did you want to unmute and talk through them?
Sure. That was great. Thank you. Lots of the same thoughts that I've been having. I'm not in a, or at least I didn't think I was in a COVID positive place, but based on what you're saying, we should consider ourselves to all be there. So the first question I was thinking through was, how did you manage, were you able to test all of the residents in your nursing home?
No, so we tested 5 rooms, which was 12 patients. Then we tested another 10, and then we tested 20. And the Department of Health in Philadelphia has been stingy with their tests. They give them to us in batches of 20 or 30 at a time. Mm-hmm. There is a CDC MMWR about asymptomatic spread in nursing homes. I have given that to people that don't trust me about this. But this is a game of asymptomatic spread. And places that are more aggressive are testing not just all the patients, but all the staff, which is just really bold. Dave Nace with PAMDA and AMDA, we're trying to get this through at the State Department of Health level. We are trying to advocate for this at the Philly Department of Health level, and even the local health systems. People just don't get it. But yes, this is an issue of asymptomatic spread.
Right. And I think that's the same concern we've had. We had a local outbreak in a assisted living facility and really found the same concern where DOH was engaged, but only giving swabs to test symptomatic residents. And we got our infectious disease physician involved out of concern, and her, she initially said, we should be testing the staff. We should be testing more of the residents, and that was not the guidance from DOH. And so it's it kind of goes against the grain in some ways and makes it more challenging to figure out how to handle the residents who are not symptomatic. Sometimes the staff, I think, are concerningly not nervous about the asymptomatic patients, and so they may handle them differently than residents that do have COVID. So I think, that was, it sounds like that's a global concern. I'm glad to hear that they're advocating at a state level. And then the other question I had, you kind of hit on at the end, and that is, I don't feel like I would trust or want to handle patients differently, whether or not they had 2 negative tests or using the suggested time-based strategy, especially if you are bringing a patient in from the hospital who had COVID. I don't think I would want to, necessarily bring them into I'm on a single unit, for example, bring them into that setting and then have staff handle them as though they would the person next door, just because they had 2 negative tests, because of the viral shedding. Nope. And us not really knowing in an older adult how quickly, that declines, so that we don't put other patients at risk. So I think you answered that as well, and that neither of the strategies recommended feel very comfortable for any of us who are being asked to bring patients in who have had COVID to a nursing home type setting.
So Penn Medicine is full of really smart people who don't necessarily understand geriatrics, and they have really rejected our definition of fever of 99.5. They have also been using a really strict definition of symptoms. And so what happens is they've designated our ACE unit as a COVID negative unit. We have had multiple patients admitted for lethargy, delirium, even falls, who ended up testing positive, and it's taken out a bunch of staff who end up in quarantine. The Penn SNF has been designated as a COVID negative SNF. Patients have turned up positive there because our patients present atypically. So I would appreciate if the Department of Health would listen to us.
Yes, absolutely.
But I would appreciate if the health system would back us up. Yes, Jackie.
Josh, there are a couple of other questions that have been coming in. I don't want to lose them.
Sure.
So Ayesha asked, how manageable was face shields for everyone?
Yeah. Hey, Ayesha, good to hear from you. So we're using safety glasses for everybody. And if you're short on that, then certainly for people who are within 6 feet of other people, including staff. We got a bunch of masks that had the plastic face shield across the front. Those are technically not supposed to be reused, but we are literally reusing everything. So yeah, that's a tough thing, but I am a big believer in universal masks with face shield. You'll hear that from Swati, you'll hear that from Sabine. I would do your best to go to Home Depot and scoop up as many as you can. In terms of safety glasses, have people bring them in for work, clean them off, and go for it again. What I didn't say is one of the big benefits of a COVID unit even if you don't have separate staff and separate HVAC unit and all that, is I would go into our COVID wing, put on one gown, one pair of gloves. I wouldn't even change gloves between patients. I would just hand sanitize my gloves off and go from patient to patient. So to me, the best benefit of a COVID unit is standardized monitoring and then one set of PPE. It's PPE conversion. If you put two positives together, now you just cut in half the number of gowns. Oh, I see this question. Hey, Amy. Yeah, probably the most supportive thing I did for the staff in terms of bereavement is we all literally went out to the parking lot and just cried together. We were all there one day together. There was a particularly difficult day where we lost quite a few patients and transitioned some others onto hospice. And that was really rough. You know, I think you have to let them know that you see what they're doing, that you appreciate it. You know, now that we're past it, I got my administrator, she's gonna buy t-shirts for everybody saying that they are healthcare heroes because they're not hearing that message from anybody else and that they help people survive COVID. I'm trying to get medical students and residents to write cards to nursing homes to just thank them for appreciation. I'm trying to get people at Penn to divert meals that are going to the hospital teams, bring that to nursing homes. I don't know. I mean, virtually anything you can think of is worth trying.
And Josh, Kimberly posted this question earlier. I don't want to lose it. So
Sure.
did you do a point prevalence test at any facilities?
You mean where we literally swab everybody? One nursing home that one of my colleagues has gotten close, they have 70 or 80 out of 120 patients infected. There's another building that I know is pretty close to testing everybody, but it's always in batches. And they have over 130 cases out of 400. But virtually everybody that swabs by geography always ends up finding a lot of asymptomatic cases. So we did try getting a respiratory therapist to help the nurses with documentation. So my nursing home is privately owned, and the owner decided to hire a respiratory therapist to offload the documentation of monitoring. It doesn't have to be a respiratory therapist. It's just a temperature and a pulse ox. It literally could be anybody. But that would be immensely helpful, is to offload that from point-click care. Yes, we are wearing eye protection on non-COVID units, and I believe they should wear eye protection when they are in the break room. They should wear eye protection in the bathroom if somebody else is there with them, because they are just as likely to get infected from each other as they are from patients. Yeah, Dan talked about assisted living facilities and personal care homes. Dan, I don't work in either of those settings, and I don't have enough brain cells to devote to that side of care as well. But yeah, I've heard you say this as well. But I think that the resources in personal care and assisted living facilities, of course, is quite lower. And so they can really run into trouble.
I had a question. How did you train how were the staff trained? I feel like, you know, while many sites have adequate PPE, particularly once they have COVID present, we're still seeing a lot of staff turn positive, and the concern is maybe they don't have adequate refreshers on donning and doffing, hand hygiene, et cetera. Did you, was there anything additional added to your staff education?
So Yeah, ideally your infection control, infection preventionist person would be the person handling that sort of education. I'll be honest, I just did it. I would devote time every single day just walking around the unit, tying people's gowns in back, telling them to move their mask over their nose, telling them to put their eye shield back on, encouraging them to help each other when they're putting on PPE to buddy up and tie each other's gowns. I mean, I'm religious. I used to not tie gowns in the back and it would fall off when I leaned over to see patients, and I was very cavalier about gowns. But yeah, everybody has to do everything the right way.
So we have a resource shared by Kimberly on donning and doffing, and we'll make sure, Kimberly, that that gets into our resource list that goes out. Thank you.
Yeah, certainly you guys can email or call me. I mean, there's some really smart folks on the line here, people that I've met before, who are also great resources as well. I would say the other thing that the hospital systems don't understand is that this is a long-term issue for nursing homes. Because even when the curve flattens for the rest of society, all it takes is one positive patient coming into our nursing home or a positive staff person, and we're dealing with the whole thing over again. So I've been telling my staff that we are going to be wearing universal masks with face shields forever. I just let them know that.
Josh, there's another question. Did you have any sudden deaths in week 2 of COVID recommended for staff to RTW of COVID positive?
So we had a patient who had a normal temperature and vital signs at 8 a.m. and at 1 p.m. coded and died. Ate breakfast and was COVID positive. That patient had been asymptomatic the whole time. We had a slew of patients that on days 4 to 7 after that initial swab all went to the hospital, maybe about 5 or 6, or transition on to hospice. So a third of my patients were asymptomatic the entire time. A third of my patients had low-grade temps that never ended up doing anything. They had low-grade temps, 99 to 100.5, and they were fine. And then some of the patients had fevers, and several days later they developed fulminant respiratory decline, went to the unit, got intubated. And then 2 patients just plummeted without warning. And so that's roughly what happened in my nursing home.
And I apologize. I read the beginning of one question and the end of another because they were coming in at the same time. So I think you addressed Ayesha's. I'm not sure if you were able to get to what Cindy posted. I apologize.
Sorry, I missed it. Was there another?
Yes. So the second half of Cindy's I read. If the 7-3 rule is not evidence-based, what do you recommend for staff to RTW of COVID positive?
So in an ideal world, I think you would do probably a combination of 2 tests 24 hours apart, and just to make yourself feel better, antibody testing, but nobody has that right now. So for my asymptomatic patients who were 3 weeks out, and at that time we ran out of gowns, so I had to make a decision about what to do about gowns. So I reserved the gowns for symptomatic patients. And for somebody who'd been asymptomatic 3 weeks, I said stop using gowns at that point. And it was kind of a moot point because we didn't have them anyway. But we still use gloves, mask, and eye shields for any patient that has been positive. And I actually haven't stopped that for anybody. Really, the only thing I would stop is gloves. And then the other question is whether I'd be willing and gutsy enough to move them out of that wing and put them back in with the general population. We haven't had pressure that way from a rooming situation. And so I am not a very brave person, and so I've been too scared to move them. Dan asked about treatment. I didn't talk about treatment, but yeah, I'm not a big fan of hydroxychloroquine. In my opinion, hydroxychloroquine is to COVID what Aricept is to dementia. It's just not the main issue. You can use it if you have nothing else to do with your time, but I wouldn't do it. There's more important things you need to focus your brain cells on at this point. Yeah, the problem with dementia is they don't do well in isolation with their doors closed. It's a problem. We've tried to allow for individual recreation therapy, but it's been really rough. And to be honest, at some point, there are some patients we don't leave in their rooms. They're going to die from isolation. So yeah, that's a problem. I will back up about the hydroxychloroquine. Tom Lawrence asked me a question. If I got COVID, would I take it? And I kind of said, maybe. But I wouldn't bank your strategy on that from the get-go. So I don't think anybody's going to get mad at you if you decide to treat your building with hydroxychloroquine. I think we all understand how desperate of a situation this is. And I think if you're worried that you've lost control of your building, which is where I got one day, and if I pulled the hydroxychloroquine trigger, yeah, I don't think anybody would have faulted me for it. Nobody. Actually, the reason I came here late is because I had a discussion with a friend of mine who's an assistant administrator at a large building, the one with more than 100 cases. And I really went to his nursing home in person to tell him that if you feel like you've lost control of your building, don't hesitate to pull the trigger and send everybody to the hospital. I said it's an extreme measure, but if you have to evacuate, you have to evacuate. He lost a ton of staff. And I think there have been some nursing homes that have held on to patients longer than they should have. And there is no room for ego or pride. Sometimes if we are that understaffed, we just have to own it up. And the health system will hate us, the press will hate us, the Department of Health will hate us. But, you know, we defend our patients. That's what we do. And if you can't handle it and because your staff is out, you may have to do that.
Nikki, was your question
I just had a question. How did you convince, I mean, PPE is just a challenge all around. Our nursing homes have kind of been left to fend for themselves until they have a COVID, and then now the DOH is pushing more PPE to them. How did you supply the face shields or the eye protection on the non-COVID units? Because that's not even really a standard in the hospital right now, at least not at ours, unless they're on, now I hear they're going to do anyone on droplet contact precautions, even if it's non-COVID, will use a face shield. But how did you have to approach your administrator and say, listen, I want every staff member in the building, regardless of where they're providing care, to have eye protection? How did you accomplish that? Oh,
so my administrator and I get along quite well. And so I didn't have to convince him at all. And weirdly enough, we actually had it. I don't know why, but we did. So we had those surgical masks with attached face shields. The Hospital Association of Pennsylvania dropped off some for us. I may have taken some from medicine as well. And the Department of Health also helped us. The local health systems have to help. If a nursing home becomes understaffed, one nursing home can take out 2 hospitals. That's happened before. And they need to share their PPE. But no, it was not a hard sell for my administrator. And I know my staff pretty well in my nursing home. And so, like I said, I just spent a lot of time talking to them about this. And thankfully, they do trust what I have to say.
Thank you.
Are there other questions or comments?
I just had one comment I wanted to make. Hi, I'm Kim Aldero. I'm from UVA, and I'm the Project ECHO program director, and in the setting of COVID, we have used Project ECHO to connect nursing home staff, directors of nursing, administrators with the geriatrics team at UVA, and have used the setting to put out all the information that's been necessary. And I just wanted to let you guys know you're not alone in this, and everything Dr. Yu that you've said has been just rung as true as ever in Virginia. So please know that this is something that, you know, even outside of Pennsylvania, we are dealing with. We are trying to connect with people to share best practices and, you know, share what we're seeing in these patients. So I think that ECHO is a great way to do that. And I appreciate you allowing me to be here.
Yeah, definitely. Jim Wright is down from Virginia, and he has an amazing story that you can hear on the Jerry Pell podcast. I don't think there's anybody in this whole pandemic that is doing more with less than people in nursing homes.
Josh, there's another question that came in from Ayesha that maybe you can address.
Oh, yeah.
What made you test the patient with 2 negatives with the antibody test?
So she was on our COVID wing, and she had low-grade temperatures and a cough, and I thought she had COVID. So we treated her like COVID. One swab came back negative. A second swab came back negative, but I didn't care because she had a fever and a cough, a fairly clear chest x-ray, and there really wasn't any other explanation. So Penn is doing antibody testing on all its staff every 2 weeks. It's an IRB study. I signed up. I haven't gotten my first blood work yet. They're also doing an antibody study among nursing home patients, and she goes to a Penn dialysis center. So the Penn dialysis center did antibody testing, and she was positive. But when all this pandemic is over, I plan on getting ID renal and geriatric folks together, because this has just been logistically the one thing I haven't been able to solve.
Any other questions or comments? Josh, I'm going to put you a little bit on the spot because you've already said that this is not your area, but ironically, today I found out that my aunt and uncle, who are in an assisted living facility, there are 4 locations, 2 are in hotspots, but they're a facility that's not a hotspot, and they got their first COVID patient today. And with assisted living, there are some patients who are leaving and coming back. They can go out and do grocery shopping, and you know, so I guess I'm concerned. It's been a rough day here. So any thoughts on getting through that?
Yeah, so the question is, what is their infection control policy? So do they have, again, this is my opinion, this whole pandemic is full of opinions. My opinion is, do they have a universal mask with facial protocol for their staff? Do they have universal testing for their staff? And how are they monitoring the patients? And how do they make sure they're not in too deep? How do they know that they are checking temperature and pulse ox in an appropriate way for an assisted living facility where they know they can send the patient to the hospital in time? So for some patients that are sheltering in their room in their assisted living facility, if nobody's coming in and out, I mean, they're going to be fine. It is, whether this is airborne or not, I think everybody likes to add their emotion and opinion to the mix at the same time. But I think if they are in their room by themselves, then that they're probably pretty well off. If anybody comes in, they should be wearing PPE, and they should wipe down anything they bring into the room. And if they're being really meticulous, I think it may be okay. So my uncle is in a very posh memory care unit, and they have been able to get it under control. but they actually have a website. I think it's called cslalerts.com, and they put on this website every case, positive case. They re-swab people who are positive to see when they turn negative. They have universal N95 with face shields for their building. I mean, it's a very rich facility, like some assisted living facilities are. And, you know, they've been able to get it under control. So
thank you for your insight. I didn't want to put you on the spot, but it was ironic that I found that out a little.
yeah, Dan Hamowitz might speak more to this than me. Yeah, Dan might speak more to this than me. There was a CDC MMWR that said assisted living facilities don't seem to be too bad, but Dan has had more experience than I have.
And Dan has graciously given me his contact information, so thank you.
Okay.
So any last questions or comments back to our skilled nursing facilities? Well, thank you so much, Josh. Thank you to everyone who had questions and provided resources. A few quick reminders and we'll wrap up. Remember that you can collect CMEs and you will get a survey. You can complete the same survey for every session that you attend to get your CME credits. All materials will be shared. And finally, we hope you'll join us for our next ECHO session. We'll have another skilled nursing facility session next Thursday, but our regular COVID is scheduled for tomorrow at noon. We have a COVID-19 session on knowledge gaps, the top 5 community questions. So thank you for joining us and for putting up with my question. Have a great night.